Hello, everyone. I'm Hamie Tawarson. I'm the Executive Director here at the National Academy for State Health Policy, or NASHP. Welcome to today's discussion. It's going to be fantastic. So glad you're here. We are hosting this discussion along with the Robert Wood Johnson Foundation. And really, this is about Medicaid innovation and how we're improving the lives of Medicaid beneficiaries and enrollees across the country. So earlier this fall, RWJF and NASHP awarded Medicaid Innovation Awards to Medicaid departments in 6 states. These nonpartisan awards recognize states for demonstrating creativity, leadership, and progress in their Medicaid programs. And I really think this kind of recognition is important, as I'm sure many of you know that Medicaid has faced significant challenges in recent years. And so taking moments to celebrate bright spots and learning from one another is empowering, and we're happy to lead however we can. So the 6 recognized states, and this all happened at the NASHP annual conference in Seattle this past year, was Kentucky for streamlining enrollment, North Carolina for improving access to care, West Virginia for improving care coordination, Minnesota for addressing health disparities, Arizona for addressing social determinants of health, and California was recognized in the category of promising emerging initiatives. Today, I am joined by Lisa Lee, the Medicaid Commissioner in Kentucky, and Cindy Bean, the Commissioner for the West Virginia Bureau of Medical Services, for a conversation about their innovative work in their respective states. Our last webinar featured innovations in Arizona and California. A recording is available for those who were not able to make it. And our next and last chat will be on January 30th with Minnesota and North Carolina. And you'll see a link to register for that event in the chat box now. So today, we are going to have really the privilege of being able to hear more about the innovations in Kentucky and West Virginia. But we only have 45 minutes, so this will be a casual conversation. We're not going to get to all of the details, but really can hope to hit the highlights. And I also hope this will spark ideas and creativity for other state Medicaid leaders across the country. But for that reason, I really did want to encourage you all to add your questions and comments directly in the chat. And we're going to be sure we save time to get to as many of those questions as we can towards the end of this discussion. So with no further ado, I want to just get started. And I want to bring the conversation to Lisa Lee and Kentucky's efforts to improve access to Medicaid eligibility. Kentucky simplified its Medicaid application process, improved marketing, and increased cross-agency coordination during the COVID-19 pandemic to streamline enrollment. The efforts were really notable, and that's why Kentucky was given this award. So Commissioner Lee, please introduce us to Kentucky's enrollment. Why did you do this, and what has been the impact?
Hello, everyone. First of all, I'd just like to start by saying that I don't think any Medicaid director does their work for recognition. We do this because we have a passion for the program and those members that we serve, and would just really like to extend our appreciation to NASHP and the Robert Wood Johnson Foundation for recognizing the efforts in Kentucky. When the public health emergency started in March of 2020, all Medicaid agencies were tasked with finding ways to make sure individuals could access treatment. Some individuals, as you know, they lost their jobs due to some of the changes through the public health emergency. So in Kentucky, we knew that there was a subset of population that was uninsured for the very first time. And we wanted to make sure that those individuals were comfortable knowing that they could access care. So one of the first things that we did was automate our presumptive eligibility process. Prior to the public health emergency, the only entities that could grant presumptive eligibility were providers. So we worked with CMS, and we declared the Cabinet for Health and Family Services an entity that could grant presumptive eligibility. We put a very simple application on a form online. Individuals could complete that form. It was very simple. We enrolled upwards of 120,000 individuals during the very first of the pandemic. So we knew we were getting individuals in the program, but of course, presumptive eligibility is temporary. We also implemented some digital nudging in the form of text messaging and emails, depending on the preference of the member, to let them know that they had an application that was still pending, maybe needed a little bit of work. And that effort with that nudging resulted in our complete applications going from about 23% to almost 75% complete up front. And so we're very proud of that. During this time, we also moved from a federally facilitated marketplace to our state-based exchange, which we call Connect. And that move is we have an integrated eligibility and enrollment system. So that move from the federally facilitated marketplace to the state-based exchange allowed us to look at applications that were coming in and process those applications and grant correct eligibility to either Medicaid, CHIP, or a product on our state-based exchange. So we were very good at getting all of our individuals enrolled, ensuring that they had access to care. And again, that was what we wanted to do. We knew people had lots going on in their lives outside of work, and then COVID on top of it. We wanted to make sure that they were enrolled and again had confidence to get access to those services that they so needed. So we're very proud of our efforts to enroll, and very appreciative of NASHP and Robert Wood Johnson for recognizing our efforts.
Thank you, Lisa, for giving us some insight on the work that you did. And we totally agree. I think we all are here because of the work that you're all doing to improve the lives of the people that you serve in Medicaid. One follow-up question. So we all are thinking about the end of the Medicaid continuous enrollment requirement. And I'm really curious, where do you see this initiative going next? Is that going to help you as you all prepare to really, think about who remains eligible for Medicaid and getting people to fill out redeterminations and all of that? How does this all fit together?
That's a very good question. And so our digital nudging will stay in place. We think that is a wonderful tool to help busy families know that they have to take some action. Our state-based exchange, of course, will stay in place also, which allows us to place individuals in the correct category of aid for which they qualify for. And one thing that we are doing, we learned from our presumptive eligibility process when we were allowed to grant presumptive eligibility from the cabinet level. We've learned a lot from that process, and we are having conversations on how we can expand that PE process to other entities, maybe. For example, we have a current 1115 waiver pending for treatment of individuals who are incarcerated. We want to start providing substance use disorder treatment to those individuals prior to their release. And we are examining and looking at whether or not we can extend that PE eligibility entity to some of our administrative office of the courts or jails, so that those individuals who are coming out of treatment will have access to necessary and needed medications and treatment immediately upon release.
Oh, thank you for sharing that, and really interesting. So in thinking about, other states and the work that they're doing on eligibility and enrollment, what do you feel like are lessons learned from what you've experienced? Were there challenges that you didn't anticipate? Are there things you've learned in this process for other states who may be thinking about this? I'm curious what your reflections might be.
So I think the challenge, the outcome was fantastic, getting all those individuals enrolled. But the challenge, of course, was related to information systems and trying to make those changes fairly quickly in collaboration with some of our other agencies. But I think that the big challenge is the technology piece and just getting that right. And we have some fantastic people in our sister agencies within the cabinet. One thing that Kentucky does have, I think that is a very big plus, is we have an umbrella agency that houses Medicaid, behavioral health, public health, and information systems. So we were able to collaborate and get those changes made and prioritize which changes needed to be in first. So I think any state looking to improve their eligibility and enrollment process, it's definitely a good idea to see what other IT system changes need to be made and prioritize those. And again, with the challenges, it's just the limitations of the technology.
Yeah, that makes sense. And then maybe one last question, and then I will we'll turn to Cindy. So, all states saw a significant increase in enrollment as a result of the Medicaid continuous eligibility enrollment requirement. Curious, you in Kentucky, do you think you had sort of above what you would have already have had with, the steps that you took to make sure people could get enrolled? And that's a wonderful thing. People, as you said, were out of jobs and needed coverage. Do you think you'll maintain sort of higher eligibility as we get through this next phase of the end of the requirement as a result of your earlier efforts?
I think we will. I think that individuals now, I think we brought in individuals who didn't know they qualified for Medicaid, and because sometimes the eligibility process can be so complicated. So I think as we go through the unwind and the continuous eligibility comes to a close, I think that we will maintain a higher level of enrollment than we did prior. And we will also focus on making sure that individuals know that they're eligible for Medicaid, and we'll use every tool in our box to make sure those that are eligible remain enrolled. And we'll also do outreach to make sure that we reach those who are not currently enrolled or who may need to be enrolled for the very first time due to changes in circumstances. So I think the lessons that we've learned during the past few years will definitely help us find and enroll all those individuals who are eligible for Medicaid and CHIP. We certainly have a great enrollment percentage right now, and we hope to continue that going forward.
Great. Well, thank you for sharing. We're going to have some time for questions and more conversation with you after we learn more about West Virginia. So West Virginia's work has really focused on improving care coordination from one of your most vulnerable populations. And through the West Virginia Mountain Health Promise Program, really want to hear more from you, Cindy, about your goals of improving access to mental health care for children in foster care, adoptive care, and kinship care. So tell us more about the program and how is it helping these kids with sort of mental health challenges?
Yeah, so our Mountain Health Promise Program, we were actually planning this at least a year, maybe a year and a half prior to the start of the pandemic. We kicked off the program in March of 2020, not realizing what a significant date that was going to be. But this program really focused on our foster care children, our kinship children, and adoptive care, which historically was around about 23,000 children in West Virginia. Now, since the pandemic, that number has grown to around 30,000 due to the continuous enrollment requirement. However, this population was not receiving coordination. They were outside of our managed care benefit. When planning for this, there was lots of concern and lots of opposition with some of the stakeholders, especially some of the advocates around managed care and foster care. And what would the role of the managed care company be compared to the CPS worker, compared to the guardian or the adoptive parent? So we really spent probably a year and a half really going over what would be in the contract, how it would work, how it would look. And the most important piece of it, that we really wanted to braid that funding between our Bureau for Children and Families, our 4E funding, and our Medicaid funding. So we would not only manage their medical care, but also those socially necessary services that children in this population receive, like visitation, parenting, and some of those things. So we really wanted to braid the funding and have one entity manage all of that. So in order to do that, it was very important for us in West Virginia to really make sure only one plan specialized in this population. So we had one plan, and we did that through an 1115 attached to our SUD waiver. And so CMS allowed us to have one plan specialized with our foster care population. And in addition to having the one plan do that, we also started what we call our serious emotional disorder 1915C waiver. And we have only one plan, which is this plan, manage that as well. So some of those kids might be the parents of means even, but even if the parents have means, we're looking at just the child and their medical needs for that mental health care. West Virginia, like most states, has a deficit in providers of mental health, especially pediatric mental health. But it was important for us to put this specialty in one plan so we could have the plan has a psychiatrist that consults with all of the teams, that we open up the plan to help us develop some of those community resources. And the other thing about the plan is they have such a tight tier of coordination. So if a child has experienced some of those serious emotional disorders, the plan itself has a 1:17 ratio for those children in the top tier of care management that really works with the MDT, the multidisciplinary team on the state level. So you have everybody kind of working, coordinating together. And what West Virginia had prior to Mountain Health Promise, we were one of the states that led in out of home placement, but also out of state placement. And since enacting the Mountain Health Promise, within 2 years, we had our out of state placement decrease from 25%, which was very significant, actually exceeded our expectations, and we're still seeing that decrease.
That's great. Thank you for sharing all of that. So, hard to launch a new initiative during a pandemic. But sounds like it was a really good initiative to start on, given the growth in the program, in the Medicaid program and the need. Curious, so you're braiding and blending funding and using one plan to really coordinate all of that. Does that mean that the care coordination extends beyond sort of Medicaid, typical Medicaid services? If services were covered under, different funding sources, is the plan sort of in charge of making sure all of those services are coordinated for the individual child?
Yeah, so the plan does. So when I say our socially necessary services, those are dollars that are historically from what our Bureau for Children and Families, or some call it our Bureau for Social Services, have. And so the plan actually is the one who authorizes those services as well. So they'll see the authorization for, the transportation for visitation, for parental visits, as well as they'll be also, doing all the medical, all the making sure you're getting to your pediatrician. And so they can actually coordinate both ends of the spectrum to make sure that the whole child is looked at. And so where we want to go, we have probably a third of those dollars, all those socially necessary dollars. The piece of those dollars that we're not managing currently are the room, board, and supervision dollars that our Bureau for Children and Families are paying. And that's our next step, is to work with ACF on how to get that next bucket into the braid.
Great. And in terms of thinking about, pulling this program together, getting it off the ground, seeing where you are, what do you feel like your advice would be for if there are other states thinking about this that haven't started on this yet? What were unexpected challenges? What do you continue to try to move forward?
I think that you have to be nimble. We have evolved throughout the program. So when we first started the program, especially our waiver for serious emotional disorders, we were the child already had to have Medicaid to qualify. And then we quickly recognized that there were a lot of children out there in West Virginia that were lacking mental health services, and because they needed that higher level of maybe some acute inpatient or a PRTF for a short time. And really, Medicaid is the only payer of that. And so what we were seeing, and it was a small number, but we were seeing some families really kind of doing some voluntary releasement of custody in order to get their child mental health services. And that's, nobody wants to see that. So we were nimble enough to recognize that was going on. And so those children can qualify for Medicaid just on the medical side, regardless of the parent's income. And the other really advice I have is really monitor your plan well. we definitely have a very strong relationship with the plan, but we have weekly meetings with the plan. We have different liaisons with the plan, so we can make sure that if there is a gap or where we see a workforce gap. And so in West Virginia, a lot of times we'll see a workforce gap in the Eastern Panhandle of our state. And what can we do as not only the state, but the plan to work together to make sure that that gap doesn't exist and that those children are receiving services. So really looking at that data weekly along with your plan is very important.
Yeah. No, those are really good things to be aware of. And I'm going to ask you one more question, and then we'll switch to the audience questions. So those of you listening in, please just add your questions to the chat. And we will get to them as soon as we have this last question. So last question for you, Cindy. So you talked about how you reduce the out-of-state placements, or those are coming down. What are your other goals? Like, what do you really want to see at, improving the lives of these kids on Medicaid and in this program?
Yeah, I mean, our next step is to really look at that preventative piece, and we're working with our university and the plan to really target those families that are at risk of being a family involved with child protective service or social services, and really target those families so we don't ever see them in the foster care system. And get some of these preventative, whether they be the waiver services or some of the socially necessary services out to those families. So not only are they not going out of state, but they're never coming into the system of the CPS system. So that's the overall goal, to go further downstream.
Yep. Yeah, that makes sense. And yes, that would be a good outcome for kids to be able to stay in their families. Great. Okay. Well, we have a number of audience questions, so I am going to switch to that. And this first question is for both of you. What are some of the key partnerships that have made your initiative successful, including any local level partnerships? Cindy, we can start with you, and then we can go to Lisa.
Our key partnership, we started an assessment pathway at the same time we did this, so that any child, regardless of whether or not they qualify for Medicaid, maybe they don't qualify for any of our services, but maybe qualify for our Bureau for Behavioral Health Services or our Bureau for Children and Family Services, so we can make sure that no child kind of falls through those gaps. So two of the key partners were our Bureau for Children and Families and our Bureau for Behavioral Health. And they really, especially on the Bureau for Behavioral Health side, they really piloted the Children's Mobile Crisis Services and those kinds of things in order for us to make it a Medicaid service. The other key partnerships is this getting the buy-in from the advocacy community, from the what we call here our DHHR workers, our CPS workers, to make them understand that the managed care program is there to help you. This is how you access them. That care manager is not there to take your job, but to be an added resource. And that took a lot of education, because there was a lot of confusion, like, well, what are they doing and what am I doing? And so all of that partnership, it takes a lot of communication to really make sure everybody understands the overall goals of the initiative and why we're all working together as one team. But those were probably our top three key partners.
Okay, thanks for sharing. Lisa.
Are definitely very important as we move forward, and our success in implementing these provisions were definitely key with our partnerships with both internal and external stakeholders. Definitely, having the leadership in the cabinet, the governor's office, and having the support of our legislative body as we move through some of the changes that we made. Our external stakeholders included our advocacy organizations such as Kentucky Voices for Health, the Foundation for a Healthy Kentucky, and the advocates were so instrumental in helping us get that member voice into our changes and making sure that some of the changes that we're doing would be acceptable We even went through a very extensive member notice update with our with our stakeholders, our advocacy organizations, and of course our provider community. We had to convey some of the changes to them, get their input, what was working, what's not. And again, I think, just those both internal and external, always looking to, leadership for guidance, our legislative body, our advocacy organization, and our members and providers are those key stakeholders that we had to collaborate with to make this successful.
Yeah, absolutely. Thank you for sharing. Okay, this next question is for Cindy. How are you working with family leader organizations and public health departments, such as children and youth with special needs programs funded through Title V on these programs?
So we have actually a weekly steering committee meeting, and I'm like Lisa, I'm fortunate that we are also an umbrella agency. So we have public health, behavioral health, children and families, child support, all under the umbrella. So they were actually very involved in our initial planning and still so. And so public health has a representative at those meetings. And so they kind of like let us know what's going on, especially with the home visiting program. So we're not duplicating services and making sure that we are coordinating those efforts with the plan as well.
Okay, great. Lisa, this next one's for you. You mentioned that enrollees could choose text or email reminders. How did you develop systems that were user-friendly, and have you heard any feedback since you launched all of this?
So that goes back to some of the technology challenges.
Yeah.
But again, input from our advocacy organizations, testing some of those messages that we had going out, getting input from our members. We developed, and our application process does have a indication or for individuals to tell us whether or not they would like to receive text and email. And we also relied heavily, I think I forgot our partners of our managed care organizations. We have 6 managed care organizations in Kentucky, and we have relied on them too to assist us with information going to and from their members. We also have, in addition to our Medicaid Advisory Council, we have about 22 technical advisory committees that we work with. So developing those messages was definitely successful with the input from all of our stakeholders, as we mentioned before. And I think that going forward, this is those nudges particularly are going to be very important for us to continue to receive a high percentage of applications that are complete upon initial submission. So be happy to get in more the technical component with that. If anyone's interested in the technical, I'd be more than happy to connect anybody who's interested with our Office of Technology Services. Yeah.
Thank you for sharing that. Okay, let's see. Cindy, this is a question for you. Our participant is curious if West Virginia's foster care plan begins at birth.
Yeah, I mean, a child can go into the foster care system at birth. It does happen on occasion.
Okay, great. Well, that was an easier one to answer. Okay, so we have a question for both of you. Okay, this is a long one, so I'll speak slowly. How have you addressed some of the structural inequities, such as power, decision-making, funding that exist within your state and the healthcare system at large? We can start with Lisa, since Cindy just answered that last one.
That's a long question. But again, I think it goes back to partnerships and the conversation we had up front that I don't think that anyone is in the position of doing this for recognition. We do it to improve the lives of those we serve. And I think that the partnerships and looking at the needs of the individuals in a bipartisan way has definitely helped prioritize where the funding goes and where it comes from. And again, the Medicaid agency is greatly funded by the federal government. In Kentucky, our FMAP or federal participation that we receive from the federal government is a little over 70%. So when we get the 6.2 FMAP bump for the COVID related, that definitely helped. And I think when individuals look at the return on investment in Medicaid and they see that the bulk of that money is coming from the federal government, it helps to prioritize funding and make sure that the funds are going directly where they need to go in order to build these systems of care and improve the lives of those we serve.
Right.
Yeah, and it's a very good question, but I think the overall goal of the Mountain Health Promise program is to empower families. I mean, our goal is to basically eventually empower families so we work ourselves out of business, right? So we don't have so many children in foster care and so many families touching the system. So that's the overall goal. But I think also, I totally agree with Lisa. I think having that collaborative, not one agency has more of a stake in the game than other. We're all here over the overall goal to help that child or that family. And so this working together in a collaborative way is probably one of the best ways to kind of dilute some of those power dynamics that can happen.
Yeah. Yeah, and I think just to reflect on sort of both of your responses, working across agency and with different types of, stakeholders out in the community, I think are integral to all of these sort of more complex policy options that you all are trying to implement, and getting feedback and understanding and really getting trust and relationships built is how you're successful. So clearly you all made significant progress in both of these initiatives to get what you got done and are continuing to build on that. Okay, a question now for Cindy. And audience, this is why we had this time, so keep adding your questions in, they're great. Cindy, how did you select which health plan became your primary health plan for kids in foster care? And it was an important choice, right? Because you wanted to be successful. So what was the process of figuring that out?
Yeah, such an important choice. And that was one of the ways too, it kind of leads back to the last question as well. We really included everyone in developing. We did an RFP.
Yeah.
But we included advocates, we included our children and families, we included our Bureau for Behavioral Health, Bureau for Public Health, and all creating that RFP. So it was like a document that Medicaid was probably more used to, like creating RFPs for a managed care agency, but we included all those other team members in what is it that you want to see this agency do. And so that's what we did. We did an RFP and it was a competitive bid.
Great. And I'll just say, you're making it sound a lot easier than I'm sure that was for agencies or groups that don't work on RFPs like Medicaid does. I'm sure it was like a foreign language. So,
it was, and actually that is one of the key things that I think that when you start working together, that's one of the barriers that you really have to overcome, because so for example, Medicaid might call it case management, our social service or Bureau for Children and Families call it wraparound with Fidelity, and how's it different from this, and really understanding the two agencies and what we're saying might be very similar or the same thing, or what are the differences. That's so important. And why I might be sounding like it was easy a year and a half, and it was very scrutinized as well. So, I mean, we were in the paper, advocates were very concerned. I will say, since the program did start and we have produced these outcomes and things are going well, I'm not saying we're perfect by any means. Things still happen in West Virginia that happen probably in every other state. But we are making significant improvements. The advocates have come on board and they like the program, and they were very nervous about the program. But I think having that pre-step of really working together, and if you want this in the contract, okay, we'll figure out a way to put this in the contract or the RFP, really helped out.
Yeah, clearly to see that shift. Okay, this is a question for both of you. So are there federal supports that would be helpful to build on the success you've achieved thus far? And we can start with Lisa first. Anything the feds can do, what can they do to help?
I think that we have a really good working relationship with our partners at CMS. And I think as we move forward, continuing to think outside the box, I think Kentucky was one of the only state, if not the only state, during the public health emergency that allowed the cabinet to be a presumptive eligibility entity. And I think that sort of thinking outside the box and support is fantastic for creating new ways to serve the Medicaid population, to find and enroll and serve the Medicaid population. So I think that sort of creativity that they demonstrated at the beginning of the public health emergency is vital to revamping and revitalizing the program as we go forward.
Yeah, great. Cindy.
I'm sorry, Hemi.
What can the feds do to help you as you sort of forward on your program? No worries. The answer was so good, you forgot.
So I think one of the things that, although our partners at ACF have worked with us some on the socially necessary services, it is still a dollar for dollar. They do. I think bringing ACF along with CMS, our partners with CMS, know Medicaid, know managed care very well. ACF, not as much on the managed care and what an actuarially sound rate means and how to account for those dollars. I think them working together more so at the federal level so we can basically blend and braid funding easier at the state level would be a huge thing for all the states to really be able to work with this population more effectively.
Yeah. And these are, some of the reasons why we chose the states we did for innovation. What you are trying in your states, I think is you're proving sort of what you can do with sort of innovative thinking and hopefully bring that up then to the federal level for them to understand and expand on some of how they approach braiding and blending funding or thinking about who makes eligibility decisions and how to think about that process. So, okay. We're going to have probably 2 questions left in the time that we have 2 or 3. And so this question is for Lisa. Does your digital messaging focus on awareness? For example, giving members a heads up of information that will be needed, or does it involve two-way communication?
So yes, our nudging is sent either through email or like I said, SMS, and it nudges those applicants to complete the benefit application process, and it includes reminders until all of the modules that they have to complete are submitted through our self-service portal. So again, we have that integrated eligibility and enrollment system, and we've launched additional campaigns to remind Medicaid members of renewal expiration dates, and we outline the steps for them to submit that verification. And we do have those two based on in English and Spanish, based on the language of the individual, their preference. And it does have a two-way communication. They can email, and that's one thing we learned through our advocacy organizations. Individuals have their own personal email, but they have an email inside our self-service portal too. So they have to check that self-service portal email, and they can communicate by email, or they can always call the individuals at our help desk.
Okay, great. Okay, this is going to be our last audience question for today for both of you, and we'll start with Cindy first. You've both shared some impressive early achievements. How are you continuing to measure success? And do you plan a next phase for these initiatives? So Cindy, how are you measuring, and how are you going to use that data to plan what comes next?
Yeah, so we continue to measure success with regards to, we have a lot of different data points that come in. Definitely one of our points that we continue to measure is out-of-state placement and out-of-home placement, but we also measure access to care, how quickly they're accessing receiving their wraparound services, and then are they receiving the other services on the waiver? Are they receiving the in-home family therapy, the respite, and the other services? And where are our gaps? And where do we need to concentrate? And so that one of the things that we did see, and I don't think West Virginia is not unlike many other states, we definitely have a lack of trained therapists out there. Our plan is actually partnering with one of the universities and one of our FQHCs in, doing some additional training and getting some additional therapists, out in some of our rural areas. So really targeting where we see a gap and trying to get the services out there, not only in person, but through telehealth as well.
Okay, great. Lisa.
So since our initiatives related to finding and enrolling individuals in the Medicaid program, we will continue to measure our success based on the number of individuals who are enrolled in both in Medicaid, CHIP, and our qualified health plans. And we'll also continue to monitor our rate of uninsured population throughout the state. We will continue to do some outreach and enrollment efforts, and we hope to do those in a way that we can identify which outreach efforts or which initiatives are the most successful in reaching the population that we're trying to serve. We do have in Kentucky a really very low rate of uninsured individuals. I think it's below the national average right now. So we will have our work cut out for us as we move forward, trying to find and enroll those other eligible individuals. But we will measure our success by the number of individuals who remain in the program.
Yeah, that makes sense. And can I just ask one follow-up question on that? Do you do any enrollee surveys just in terms of their experience?
We have not done any enrollee surveys, but we believe that our advocacy organizations have done some of those.
Okay.
And as a matter of fact, I participated in a conference earlier based on member voice. So that's something that we definitely want to continue to explore and bring into the program, is how our enrollment efforts impact those individuals that we're trying to reach. And I think that sometimes our members are a little bit reluctant to sit in meetings or have surveys with state staff there. So our advocacy organizations, again, are very instrumental in helping us maintain that member perspective and get that member voice in all of our processes as we go forward.
Yes, that's a really helpful point. Okay, well, we are going to start to bring this to a close. I did see one question in the chat about a fact sheet on West Virginia. So that is being completed. So that will be shared. And there already has been one shared on Kentucky. So I just have to say thank you to both Lisa and Cindy for being here today, both for their leadership on these initiatives, their focus on really improving the health of the people that they serve and their entire team, focus on what hasn't been an easy time for Medicaid. So we really appreciate that, and you're taking the time to come talk with us today so people can learn about what you've been doing in your states. I hope your experiences can inspire work in other places in the country, and even perhaps at the federal government level, of thinking about how to really expand on new ideas. We all need new ideas. These are challenging problems of making sure people can get the access and services they need, especially when there's so many things that are in their way in terms of barriers. So thank you again. It's been wonderful. And we just, for the rest of the audience, we hope you can join us on January 30th as we continue this Medicaid Innovation Award discussion with Medicaid leaders from Minnesota and North Carolina. A link to register for that event is being shared in the chat, and we'll be sure to include it in a post-event email that you'll all receive. And also, before you go, if you were attending, please take a minute to complete the brief survey in the chat, and with just thanks from all of us here at NASHP and on behalf of the Robert Wood Johnson Foundation. Thank you for supporting the Medicaid Innovation Award and for really providing an opportunity to highlight the great work of the states across the country. I hope everyone has a wonderful day. Take care. Bye, everyone.